I'll now introduce Dr. Anup Patel. Dr. Patel is a child neurologist and epileptologist at Nationwide Children's Hospital, where he's associate professor of clinical pediatrics and neurology. Dr. Patel also runs the complex epilepsy clinic there, and I've actually interacted with him most as the president-elect of the Child Neurology Foundation, really bringing attention to the diagnostic odyssey for patients with epilepsy. So Dr. Patel, take it away.
Thank you so much for that kind introduction, and thank you so much for having me today. It's an honor to be a part of this esteemed group and participate in this conference. I share a lot of what Tracy said earlier, that it's amazing work we need to do, and if we can do that, we will make sure we get these kids treated properly and more effectively. All right, let me go ahead and share my screen. Okay. Can everybody see that then properly?
Yes, we can.
Great. So I'm going to go through some of the causes of LGS, and I really want to go through and highlight and bring in a lot of what has been discussed today into my presentation. So we're going to go over epileptic encephalopathy, even though it's been covered. I want this audience to take that definition that we'll go through and how it relates to LGS and how it relates to the different etiologies that we see within this disorder. Here are my disclosures. So we've heard a little bit about epileptic encephalopathy, but I want to put a little bit of a spin on that. You see the definition in front of you as it relates to, epileptic activity contributing to the actual mental and neurological decline. And I think that's a very strict definition we need to stick to, because when you look at the EEG patterns that have been talked about with LGS, even when they change over time, they're driven by that same common feature and pathway, despite having different etiologies that we're going to talk about. So Engel has a really good definition that I like as it relates to epileptic encephalopathy. And by the way, my references are at the end of the presentation for anybody that wants them. But basically, the biggest issue is that the epilepsy-dependent neurodevelopmental or process as it evolves. So it's really not the underlying etiology that's driving the changes as far as development and intellect. It's the actual epileptic activity. And that sometimes is very difficult to be able to dissect, because as we talk about in a little bit, many of the etiologies of LGS are also going to have that tendency or could have that tendency. But that's what I think makes LGS a little unique in the spectrum of developmental epileptic encephalopathies and as it relates to other etiologies for epilepsy that were kind of discussed earlier today. So remember, it's not because of the pharmacotherapy. So if you have a child who's had sleepiness because of side effects on anti-seizure medication, obviously that's not related to the epileptic encephalopathy. So why am I making a big deal about this? Because I think that's part of the challenges as it relates to etiology and understanding etiology for LGS. Which part of the LGS features contribute to the epileptic nature of that activity for the developmental issues versus some of these other factors? And it's very difficult as a clinician sometimes to be able to tease that out and understand which is related to which issue. As we've talked about, it's a challenging diagnosis. Obviously we're going to talk about the etiologies, and they're multiple, has a very typical or clinical presentation. Obviously the multiple seizure types can confuse people and make that difficult sometimes for diagnosis to be achieved early on. The features on EEG do change. It can be confused, like Dr. Whirl mentioned, with other diagnoses. And, we have a lot of disagreement related to the importance of the diagnosis, criteria has been evolving, etc. But I want to spend a minute or two on why the diagnosis is so important. Well, we know there's some recently approved treatments that Dr. Wheelis is going to cover that was for LGS. And you may not think that's necessary, but it really is important, because that allows a focus on the diagnoses, the disease state, but then also highlights, and for insurance purposes, opportunities to get treatments maybe a little easier than if they were not FDA approved. But if we look at diagnosing LGS and the etiologies behind it, then we can actually now start to monitor it. We can talk about that spectrum that Tracy eloquently mentioned at the beginning of our day and really understand the areas and factors as it relates to different time points along that spectrum. And if we really recognize these children early, perhaps we can get them on proper treatments, and perhaps we can improve their outcomes. The other related issue is allows us to then potentially identify those etiologies. So the advent of genetic testing, which we'll talk a little bit about, and many of the current group that's on this call are by far more expertise in it than I do and have a better understanding, but have also contributed greatly to the appreciation and understanding of different etiologies. And then research opportunities. So we are here for meeting of the minds to bring us together to start thinking of different ideas, but they will hopefully lead to some opportunities down the road. And most importantly, we have a great foundation. We have a great foundation led by many of the folks on this call as well, who've done an amazing amount of work for the patient population and their caregivers. So when we look at the causes of LGS, and we've mentioned a little bit about some of those, but 65 to 75% of patients now have an identifiable cause. I will say it's probably likely higher. I mean, we're not publishing all the other etiologies, so it's probably higher with the advent of genetic testing, and specifically as it relates to, whole exome testing and epilepsy panels. I feel that the etiology of the unknowns, which I want to spend some time on later, perhaps have some learning opportunities related to genetic testing, and is there an opportunity there? The other things that you've heard of, and we'll break this down as far as the structural changes to the brain. You notice I said structural changes because there are obviously lots of changes that can change the actual structure of the brain that can contribute to the LGS picture. We mentioned genetic variations, metabolic disorders, and we've all heard the statistic that 20 to 30% perhaps had a previous history of infantile spasms. So obviously there's a link behind the etiologies related to infantile spasms, or what Dr. World mentioned, the infantile spasm syndrome, and the development of LGS. So let's talk a little bit about structural causes and the contributions it can have to LGS. So we talk about birth asphyxia, or HIE, hypoxic ischemic encephalopathy. And it's important that we understand that this can be a factor or an etiology for LGS, because there is a lot of great work done by neonatal neurologists and neonatal epileptologists that can help in that regard early on by doing things like cooling protocols, et cetera, that hopefully will help decrease the chances of developing long-term epilepsy or things like Lennox-Gastaut syndrome. What about traumatic brain injury? Don't forget that it's not all related to HIE, that in some cases, LGS comes about after a traumatic brain injury, after a motor vehicle crash or some other trauma to the brain that changes the structural content in those cells. We talk about congenital infections as also a potential etiology, again, focusing this on the neonatal period or in the early life periods. And then brain malformations are also a structural cause. So being born with a different structure to your brain or areas of structure to your brain. It is very important we understand these etiologies because they have treatment-specific opportunities, perhaps even for resective surgery. But we'll talk about that in Dr. Wheelis's presentation on treatments. What about genetics causes? So many of the folks on this call and helped to organize this presentation in this day contributed to this medical literature. There's a lot of different genetic causes that are listed on here that have been reported in the literature. I wanted to be sure that I kind of looked at some of the more common ones that we've seen or maybe are aware of and how it relates to Lennox-Gastaut syndrome. Well, here's where I want us to start answering or asking ourselves some questions. These are very distinct genetic etiologies. Some have some familiar pathways or network developments that can lead to seizures, but in large, they are very succinct or very unique in that sense and affect different genes or different areas of genetic variations. How and why do these things lead to the network development of Lennox-Gastaut syndrome? You can also say that not everybody with these genetic variations are going to develop Lennox-Gastaut syndrome. In fact, that's very true, that not all these patients with these genetic variations are going to go on and have Lennox-Gastaut syndrome. So again, here's another time point for us to say why. What can we learn about these specific etiologies that help us understand those that do develop the LGS spectrum or those that don't? But I want to spend a little time on something maybe unique. You know, most of us already knew all that information. I probably wasn't presenting something specifically or super new for anybody. But I want to talk about a good study or a couple studies related to unknown causes. So these unknown causes were found to have more likely to have normal development or mild delays at onset of etiology or onset of presentation. They may have occurred later at age of onset, so maybe past that typical time frame that was discussed earlier. Normal brain imaging and neurological examinations, perhaps absence of dysmorphic facial features or other features that would be more present in a genetic cause. These patients are less likely to have infantile spasms, and perhaps they have better treatment outcomes. But let's dive in a little bit more on this so we can potentially have a learning opportunity as it relates to etiology for LGS. So when you look at this paper, the Epilepsy Phenome Genome Project took a lot of the patients, who had an unknown etiology for their LGS diagnosis. They had strict inclusion-exclusion criteria, which I'll talk about. They also were evaluated by a panel of experts to make sure that they met the inclusion-exclusion criteria. So this was done independently. It's very similar to what's done now in many of the studies that are ongoing for treatments related to Lennox-Gastaut syndrome or even epilepsy syndrome such as Dravet. So the inclusion criteria for this study was generalized spike and wave or GPFA. They had to have a normal brain MRI, so no structural abnormalities, no family history of epilepsy. However, febrile or provoked seizures were allowed. The exclusions were listed here. So obviously you didn't want to exclude, or you wanted to exclude somebody in the unknown category if they had a known etiology. So that's the genetic syndrome or torch infection, known metabolic disease. But they also excluded premature infants or anybody with structural MRI changes, the HIE, infection, stroke, or had an autism spectrum disorder or severe delay prior to the seizure onset. And that was a very key distinguishing feature, prior to seizure onset. So what did we learn? What did we know about this population? Well, they had 155 patients overall. The mean age, again, was suggested to be older than you would typically see. The median age was 14 years. 66% of these patients were men, 34% women, 77% were Caucasian, 7.4% Hispanic, and 91% were born in the United States. That's a little bit of a misleading statistic because the majority of the sites were in the United States. What about findings? What did these patients have? Well, 55% had tonic seizures, so maybe not as high of a tonic seizure rate as we would expect in a typical LGS patient. 60% had generalized tonic-clonic seizures, and their EEG frequency varied from 1 to 5 hertz. And 48% of these patients were greater than 18, or who were greater than 18, completed a secondary school. So why did I bring this up? Well, I think that's one of the challenges we have. We need to have a strict criteria because perhaps the etiologies are going to be more known if we separate the diagnoses based on the strict criteria. Based on what Dr. Whirl and even what Tracy mentioned, Dr. Salazar mentioned, some of these patients may not have or consider to have Lennox-Gastaut at this point. And why is that important and why is that necessary for us to understand as we learn about the different etiologies? Well, because there's lots of questions that remain. And those questions are, what are the unknown etiologies for LGS? How do we find that? Will whole genome testing help us? Dr. Paduri and I led a cool exercise that we're going to present at the Child Neurology Society annual meeting on looking at whole genome testing in patients with epilepsy to see if there's etiology can be found. But that's very important because genetic etiologies can teach us a lot. They could teach us a lot about pathways. They could teach us a lot about networks. They could teach us a lot about seizures and potentially have augmentation as far as genetic therapies go. But why do these different etiologies? I presented very distinct etiologies to you today. Some are caused by genes. Some are caused by genes that are related, but some are caused by genes that have no relation to each other. And some are caused by structural changes. Some of those changes are not inherited or at birth. They were causative from either being premature, having some sort of brain changes, et cetera, that we talked about. But why do these have the same network pathway, EEG findings? Why do they develop in that same sort of trajectory? What more can we learn about the natural history? If we understand etiology and are able to do that and diagnose early, we can follow these kids and develop patterns to these kids as they go in and travel through childhood, through adolescence, into adulthood. It will be very important for us to know those pain points or those ideas or opportunities that Tracy eloquently showed on her slide. And why does this phenotype exist, and how do we prevent it? I've often found this question to be very important, because what about this specific pathway or idea comes together to cause this difficult to treat epilepsy, intellectual impairment, and obviously all those things Tracy eloquently said as it relates to being or having a child with Lennox-Gastaut syndrome. It is obviously very difficult at times and can be very devastating. And these patients go down a road that many others do not have to go down. And why does that happen? And how can etiology help us when we know it's such a varied presentation? So with that, I'll stop. I'll turn it back over to our colleagues to answer any questions that people have, or we could go obviously on to the next session. So thank you for your time. And again, thank you for this wonderful opportunity to present and be here with you today.
Thanks so much, Dr. Patel. We do have time for a few questions. We've been receiving questions from the live audience as well as the web audience. So I think we can begin to start to address some of them to you. The first that I see specifically for you, Dr. Patel, is with a question regarding a child who had infantile spasms with initial diagnosis at onset at 5 months of age. And whether you've seen patients with spasms starting around that age with cognitive improvement or better control of seizures over time.
Yeah, I think, obviously the earlier you recognize children with infantile spasms and getting them first-line treatment in a timely fashion can obviously improve their outcomes. So when you look at, the precursor of infantile spasms, it's very important that we could potentially augment the future as far as being more treatment responsive. But that really depends on getting them the first-line treatment and diagnosis early on. As far as the etiologies of those goes and how that then presents over time, I think we still have an opportunity to learn more about why some of the patients with infantile spasm syndrome respond versus others. It's not just based on time of presentation or time of treatment, but absolutely, I think we've seen patients that can go different ways, but again, it all depends on how they're going to respond to that first treatment for spasms. I will say that, Tracy mentioned during her talk that Kelly Nutt says that she can recognize or know when LGS is developing. I also feel that way very strongly. Like there's almost a pattern that you could predict. I call it, and John Meidinger and I debate this or talk about this all the time, they're evolving out of that hypsomyrrhia pattern into that LGS pattern. And you can almost see that trajectory occur. And I think, again, that's an opportunity for us to learn what are the features from a network standpoint that exist during that transition and how can we augment it.
Yeah, and how can we then intervene, just at the cusp of recognizing that if you feel like somebody's reached that threshold, how do you then intervene, or can we intervene to keep it from progressing? Absolutely. We have a question from Dr. Worrell for you and for the general discussion later, but I think it's a good time to bring it up now. Do you think some of these heterogeneous etiologies that we've talked about might lead to excessive neuroinflammation, or can inflammation further exacerbate the epileptogenic process?
Yeah, I think the latter is probably more true than the former, meaning that the neuroinflammation can exacerbate that process. And is that part of the learning for us to understand that pathway and why it develops the way it does, or that network develops? Tracy and I have talked, my theory is around this network propagation and organization around the LGS spectrum. And why does that happen? I definitely think it's, I would like to think that it's probably augmented or worsening by the neuroinflammation in that case. But again, I don't think we know specifically. And so if others have some ideas on that too, I'd love to hear it.
Maybe we can let people contemplate that during the next couple of talks and come back to the big group discussion. There was one other question about the Epilepsy Phenome Genome Project and what methodologies were used there. So Heather and I were involved in that actively, and I can certainly address that. It was really starting off with trio exomes for what we then called epileptic encephalopathies patients, but Anup, maybe you'd want to talk a little bit about the CNF project you mentioned in terms of evolving methodologies.
Yeah, and so what's really exciting about the CNF methodology is that, the technologies is only as good as you have. And so, we did a really great job, and people really understood a lot and were able to diagnose patients that were in that unknown classification. So what we did in the Child Neurology Foundation project is we had access to some whole genome testing. And so really what Ann and I did was we really looked at centers could submit cases for review or consideration to get the whole genome testing. And Ann and I independently went through that to see if we felt these patients could be good candidates for whole genome testing. And some of that criteria was, obviously epileptic encephalopathies or treatment-resistant epilepsies that had some previous genetic testing that did not yield an etiology. I won't tell you what we found because I really want you guys to attend our presentation when we get to Boston. But please look out for that because there's obviously learning opportunities for that. That hopefully takes a lot of the great work that Heather and Ann has done and others on this call to the next level.
That's great, Anup. Thanks. I'm really excited to hear those results in Boston. And I think one of the questions also was about the just building on that question. The question overall was about the technology used for the EPGAP project, which really was exome, but many of the patients had karyotype or FISH or chromosome array before that. But I think the important thing about that study is it wasn't, none of them had exactly the same workup prior to that, right? And so I just wanted to comment that I think it's important we still think about some of these, what we call older technologies, which hopefully will be supplanted by good whole genome sequencing that can detect a little bit of everything. But we can't forget about the importance of karyotype for diagnosing things like ring chromosomes, which might be associated with LGS in some cases.
And then Heather, I don't know if you want to talk a little bit for a second about the genome attempts using old samples and so on with that with that formerly collected cohort to maybe encourage the group to get fresh samples.
Yeah, I think there are a lot of projects ongoing to think about using genome technology, and we can talk about that in the discussion period, but I think it's an important step forward. But is important probably to use blood samples, and they don't have to be fresh, but they can't be degraded. Yeah, so I think this is going to be a really important way for us to think about how do we diagnose some of those patients that we have not yet been able to find a genetic diagnosis for in the cases that we think are genetic, right? And that's kind of one of the big challenges. That I should say that the Epilepsy Phenome Genome Project also did some genome sequencing in a small subset of cases, and that analysis is ongoing, and hopefully there'll be a paper coming out later this year about the results of that study, which I honestly don't know, but I think the analysis should hopefully tell us something as well. And many of those were LGS patients.
Yeah, and I think that as it relates to LGS, one of the things I hope is that as that work starts to come out and as we start to get more understanding of genetic variations that are, part of the LGS diagnosis or etiology of the LGS, what can we learn about those? Like, well, how much, what percentage of patients with such abnormalities go on to have LGS? Which ones don't? And being able to bucket that, I think, will be a very huge opportunity for us to learn from. And again, it all starts with getting that etiology as early as you can. And like Heather mentioned, I could not agree more. I mean, until we have to understand the limitations and usefulness of all genetic testing, right? Because it's not just, oh, I'll just get an exome and be done with it. No, del dupe, you got to wear, So having guidance along those lines, I think, is still very important, but then mostly having a great understanding and learning from those opportunities are going to be where we go. Because if these genetic therapies become more profound and useful, then what can we do that'll allow us to act early to potentially augment that etiology, right? Like if you can potentially treat the gene variation, what effect does that have? I don't know. We don't know that yet, but it's important that the etiology is there.
Yeah, and I'll just comment that I think even though we don't have targeted genetic therapies for all of the causes yet, having that genetic diagnosis early and being clinical trial ready when they emerge, I think is very important. And that's not always an argument that you can use with insurance companies, but about thinking about ways to do the genetic testing early, like Dr. Patel said, is so important so that we can gather the clinical information, the genetic information, and be ready to jump in when new therapies emerge.